Bueno, buenas tardes, vamos un poquito retrasados. Bienvenidos a este simposio sobre efectos de la inmunosupresión. Inmunosupresión que ha ido avanzando a lo largo de los años y que nos ha permitido minimizar en gran parte la disfunción inmunológica del injerto hasta cifras de aproximadamente un 15%, lo cual puede ser un granito dentro del campo del trasplante renal. Pero quedan gaps, quedan incertidumbres en esta inmunosupresión, como podrían ser la implementación o no de las biopsias de protocolo, nuevas terapias para pacientes hipersensibilizados o el manejo de infecciones asociadas al trasplante renal, que sin duda nos despejarán y que nos aclararán muchas de las incertidumbres por expertos que van a presentarse aquí hoy en estos temas en concreto, de reconocimiento internacional, y que yo creo que van a disfrutar de todos ellos.
Pues bienvenidos a todos. La idea es, en contraste con la sesión anterior en la que hablábamos de riesgo cardiovascular, enfermedad renal y esas cosas que compartimos todos los nefrólogos, aquí nos vamos a centrar en el efecto de la inmunosupresión. La primera ponente es Elisabeth Van Loon. Es una joven nefróloga que ha trabajado mucho en el campo del trasplante en investigación dentro del grupo de trasplante de Leuven, y además es reciente premio Da Vinci de la European Society of Transplantation. It's a pleasure to have you here. And she's going to speak to us about protocol biopsies and when are they necessary in order to measure the effect of immunosuppression. So welcome, Elisabeth.
Hello, everyone. So I'm Elisabeth van Loon. I'm from Leuven, Belgium, so I'm sorry to not speak in Spanish for you. Thank you very much for the introduction, Martha, and thank you very much for the invitation. So I was asked to address this question about protocol biopsies. When are they necessary? And although this is a very straightforward question, I think the answer is not that straightforward, and I will explain you why. So first, the definition, what are protocol biopsies especially? Well, in this session, we will talk mostly about biopsies in kidney transplant recipients at time of stable graft function. However, this is not a very defined definition. And so this also means that there is actually no standardization of actually the definition of protocol biopsies. And so in practice, every center has their own policy regarding these protocol biopsies. So why would we perform protocol biopsies? Well, they have the potential to identify acute and detrimental events early before irreversible damage would develop. And so they can detect, for example, subclinical rejection, which we can then appropriately treat and before longer-term outcomes might actually be worse. However, that also the treatment of subclinical rejection is also not standardized, and so there's also no consensus there on how to treat these subclinical rejections, as I will show you later. We can also use protocol biopsies to monitor chronic histological changes like chronic rejection, recurrence of glomerulonephritic diseases, and also drug toxicity, which will also allow us to modify our immunosuppressive drugs and prevent further allograft injury. And then finally, protocol biopsies are also interesting for research purposes. They will help us to follow the natural evolution of allograft pathology. And for example, in the iWorks prediction tool from the Paris Transplant Group to predict long-term outcomes of allografts, also these lesions from the one-year protocol biopsy can be included to improve your prediction. And so this is what most centers do, the indication biopsy. So when eGFR drops or when proteinuria rises, we do indication biopsies to detect rejection. And this is what we do when we do a protocol biopsy. So per definition, the eGFR and the proteinuria are stable. And we do a protocol biopsy to see if there is any subclinical rejection going on, to then detect this early and treat this early on. And so when we look at the prevalence of subclinical rejection, we see that, of course, in clinically indicated biopsies, the prevalence is much higher. We will find rejection in almost 1 in 2 of these clinically indicated biopsies. However, in protocol biopsy, when the graft function is stable, the prevalence is much lower, with only around 10 to 15% of these biopsies showing subclinical rejection. However, if you are a center like ours in Leuven that perform protocol biopsies systematically, we have much more protocol biopsies done than indication biopsies. And so in the absolute numbers of our rejections in our centers, there's actually more subclinical rejections than clinical rejections found. And so the burden is actually still quite high. And so this is why we want to detect subclinical injury, because we know it has worse graft survival. This is from older studies mostly, with this one already almost being 10 years ago. And then, of course, what are the disadvantages to perform protocol biopsies? Of course, they are invasive, which causing stress to our patients. They ask for a lot of logistical organization for your center. And in general, for all biopsies, we only take a very small core. So there is a possibility of sampling error where your core is not representative for the entire kidney. Also, it's only providing a snapshot information of that time points. For example, if you would only perform protocol biopsies at 2 years, you might detect some chronic rejection, which is not amenable to treatment anymore, while you have missed earlier events, like subclinical rejection, which was more active and which you could have still treated before. And so in practice, if you want to implement protocol biopsies, they should be done safely, reliably, they should be patient-friendly, informative, they should have some implication. And so in practice, I think most centers and our center are doing this like this. We have an outpatient clinic with trained operators. We do it under ultrasound guidance, under local anesthetic, with an automated biopsy gun. And doing it like this, the risk of complications is actually quite low, with only 1% having microscopic hematuria and less than 1%, much less than 1% having graft loss in protocol series. And so, as I told you before, the protocol biopsy policy is not standardized across centers in Europe, but also in the States. Either if you do perform protocol biopsies, yes or no, when you perform them, and then also the therapeutic implications of finding a subclinical rejection is also not standardized. And this I will illustrate with this survey that was done in Europe, looking at TCMR mostly, but also having some interesting points for here. So this was a European survey looking at 129 unique centers from Europe. And we see that actually 43% of centers never perform any protocol biopsies. 36% of them perform always protocol biopsies in every patient, and then only just 21% is performing protocol biopsies in specific groups of patients. We'll go over this. And then also in the treatment of subclinical rejection, and here we focused on TCMR, we see that in protocol biopsies, also the treatment response is not very standardized across centers. When you find a borderline rejection in the protocol biopsy, 67% of centers will treat it with high-dose steroids and 34% will increase their baseline immunosuppression. When there's a TCMR grade 1 and 2, the consensus is higher and most centers will treat these with high-dose steroids, but whether they will change and increase the baseline immunosuppression is not that standardized. And then these studies looked at an economic analysis, and in this study from the United States, they found that protocol biopsy screening programs are cost-effective, yielding more quality-adjusted life years, but this is of course in the United States and maybe not that translatable to European practice. And so I think there's multiple rational approaches to perform protocol biopsies. Either you don't perform any protocol biopsies, but you give your patients powerful immunosuppression, with of course the disadvantages of this powerful immunosuppression to your patients. Either you perform biopsies limited to high-risk recipients only, or you do universal biopsy screening programs. And so I think the appropriate method depends on your center. It's a decision for each transplanting center on its own, depending on the immunosuppressive drugs you give, depending on the risk of your population, the immunological risk of your population, and also the procedural costs in your center and the experience you have with protocol biopsies. And so low-risk patients with powerful immunosuppressive drugs will have a really low yield of finding a subclinical rejection in protocol biopsies. But when you have highly sensitized patients, or when you do immunosuppressive drug minimization regimens, I think it might be interesting to do these protocol biopsies to prevent avoidable graft loss. And so the upper part I have been showing you, so we can see a stable graft function even when there's already lesions going on in the biopsy. However, even before these lesions, there might be some transcriptomic alteration already with immune activation signals that we could be able to pick up with non-invasive biomarkers like blood and urine biomarkers. And although these biomarkers might be really helpful in detecting subclinical rejection, I'm not sure if they might totally replace biopsies, because there is also quite some value of histology that we cannot really entirely replace yet with non-invasive biomarkers. For example, also the chronicity of the lesions is very important. If your biopsy shows a lot of chronic damage, you might not consider giving high-dose steroids for some active inflammation still in it. You can also look at the severity of the lesions, whether it's an ABMR or a TCMR rejection. And then also you can find some other information that these non-invasive biomarkers might not have shown, like viral inclusions or recurrence of glomerulonephritic diseases. And all of these will have therapeutic implications for your immunosuppressive regimen. And so these are still very important, and so these biopsies are still necessary to adjust your immunosuppressive regimen. Nonetheless, I think biomarkers might be very helpful in guiding our biopsy or protocol biopsy programs. And for example, here in this study that recently came out, we studied urinary CXCL9 and 10 and combined these with some clinical parameters. And when we combine this model and look at, for example, in stable allografts, so when we would normally do a protocol biopsy in our center, if this model is indicating a low risk of rejection, we put a cutoff here at 10%, we could actually safely avoid almost 60% of our protocol biopsies, which were not necessary. And so in conclusion, I think there is some pros and cons to the performance of protocol biopsies. The pro is, of course, that we could detect subclinical injury early. We know that it's detrimental, and so we could allow for timely adaptation of our immunosuppressive regimens. And then, of course, the cons are that it's invasive, and there's also the flaws of histology, with especially the sampling error. And so it's clear that it's not a standardized practice, and I think it should be left to each center's discretion, because it should be based on your immunosuppressive regimen, whether it's very powerful or you do a drug minimization protocol, and also the immunological risk of your patients and the experience and the resources that you have in your center. And then I think in the future, these protocol biopsy programs can actually be guided by non-invasive biomarkers, allowing for indicating when protocol biopsy should be done to have a higher yield of finding these rejections and avoid a lot of non-necessary biopsies. Thank you very much for your attention. The discussion will be after, so happy to take any questions.
Thank you. Thank you, Elizabeth, for your interesting and amazing talk.
Now I am introducing Han Hurst. He's the leader of the research group Transplantation and Clinical Virology, and he's been leading the new guidelines on BK infection, BK problems in transplantation. So thanks for being here.
Thank you, Martha, for the kind introduction, and my apologies for not speaking Spanish, and I try to follow though. So as you've seen, I'm a virologist, and viruses take the host from inside, and I'm glad there's a little slot for this today. My disclosures. So you were invited to do a new set of guidelines to define the baseline, and hopefully in the future, this will be a great starting point for new developments in the treatment of this insidious complication after renal transplantation. Camille Cotton and myself, we were asked to put together a team and review the literature, and that's what we did. We invited more than 80 international experts to help us with this endeavor, and we formed 6 working groups with 2 leaders, reviewed the evidence, and then tried to grade them. And we met in Basel in April 2022. And there we had intense discussions on the first set of slides, and then tried to develop a manuscript draft by June 2023. So what is this all about? Well, the starting point, everybody agreed, should be the guidelines as we put them down for the American Society of Transplantation that was published in 2019. And I'd like to recall that all of us are more or less infected with this agent BK polyomavirus. 10% of the healthy immunocompetent blood donors, for example, shed the virus at low levels in the urine. However, when you go into transplantation and receive immunosuppression, about 10 to 20% develop this complication. The good news is that 90 or 80 to 90% do not develop this complication. This is characterized really by destruction of the renal allograft. You have high-level virus replication. These individuals shed high levels of virus in the urine, more than 10 million copies per ml, and accordingly there is a progression scale. So the clinical diagnosis is very much assisted by measuring virus in the different compartments, such as the blood. So a probable case is a person with high-level urine viral loads, and a probable case is one that has new onset, persisting viral anemia detected in the blood. And when this increases over a certain threshold, like 10,000 copies, then this is a presumptive diagnosis. At this early stages, very often the protocol biopsies, because these patients do not have any changes in renal function, they're at a normal level and you have a good chance of missing it. However, objects in the mirror, and this is really the case. I think this is the one thing that you should remember. In fact, the anemia is an equivalent of ongoing replication changes, viral disease that we have not detected and are unable to detect early by allograft biopsies. So here we have the assembly in this hybrid meeting. About 1/3 of participants were joining us electronically, and we were trying to work out these guidelines. On the left, you see the schedule. We had several haulovers of and suggestions on the slides. We had different chair people, and the grade characteristics are A, strong recommendation, and B is a moderate recommendation, C is weak. And these are really graded by strong, we recommend, or we suggest, and everything else we really tried to have as statements only. So now we're 18 months later, the manuscript has been submitted, 1 table, 1 text box, 2 figures, 117 pages, 356 references, 1 supplement with 12 tables, 124 references, 35 pages, decision pending, and I have another 10 minutes to explain to you what's in these guidelines. So let's start with the simple stuff. You look at the transplant patient, you wonder if this patient is at risk for BK virus nephropathy or BKD anemia. And you can see on the left the recipient factors for the D anemia. And we have usually better evidence for that because the numbers are higher. We have also more studies that look at this. So an older male recipient has naturally a higher risk for developing this complication. And then there are other issues that we usually don't test for. For example, if the patient is seronegative or has very low antibody levels and has received a graft from a donor with very high antibody levels. So what about the transplant factors? Really, the disease came out when we're using more potent maintenance immunosuppression like tacrolimus and mycophenolate, and obviously, as compared to cyclosporin, tacrolimus is a risk factor, and also rejection and high-dose steroid treatment is a risk factor. And obviously, mTOR inhibitors reduce this, but this is really compared to mycophenolate and often in a combination with low-dose CNI. So on the donor factors, we don't know very much because we usually don't test the donors very well. So this is definitely an area of study. But urinary shedding, just as you have seen for a healthy blood donor, that seems to be a risk factor that the virus replication is already active. And then if we put the kidney where the virus lives naturally into a host that we now immunosuppress, then the risk factors are very high. If the recipient is an older male and has not seen the virus for a long time, then obviously there's a higher chance for this to develop. Now, the pathology, which has been providing the gold standard in case you detect the disease, they have acknowledged that the molecular tests have become much more valuable. So they recommend that in the case of a stable graft function and detectable D anemia, you don't need to do a biopsy unless this is clinically indicated, as Elizabeth told you earlier. However, if you have a patient with high immunological risk on which you want to now reduce immunosuppression, maybe that is a good idea to take a closer look before you go into this strategy. And then obviously the pathologist wants to have everything on board. He wants to look at the viral loads, he wants to look at the clinical data, so he can come up with the best interpretation of the findings that he has. So it's no longer just the biopsy that tells you all of this. The future directions, and that's an important part of these guidelines, really says we should look at the BENF PVL strategy and compare that with the ASD strategy, because I think the comparison is not yet clear. So the jury is still out which of these staging protocols is actually more informative for treatment response and for allograft survival. So protocols that can distinguish between different polyomaviruses of interest because currently the SV40, the monkey antibody, recognizes BK, JC, and SV40. So it would be nice to also have differential techniques available to distinguish BK from the more rare JC virus nephropathy. And then, of course, and this is also going into the future somehow, non-invasive assays that provide information equivalent to a kidney biopsy for staging BK nephropathies and forms of acute and chronic rejection. And maybe we need most. We need biopsy tissues for this as much as blood samples and urinary samples. So diagnostics was really strong on recommending that we should screen these patients, and the best algorithm was considered to be monthly screening up to month 9, and then every 3 months until 2 years post-transplant. And really, the kidney transplant recipients that require increased immunosuppression or anti-rejection therapy, that you, from then on, reschedule a 3-monthly screening. The future of the diagnostic is really to have commutable international standards. I'd like to remind you that the currently international units are based on a problematic standard that has unequal levels of early and late viral genes. So that is not commutable for centers that have an assay that targets the early viral genes. Utility of donor and recipients immunology, serostatus, serotype, neutralizing antibodies, and CMI, that's the future. We need much more work on this in order to harness this information. But remember that these items are also difficult for cytomegalovirus, even though there's much more information on CMV, so a long way to go. So everything, is centering around PKD anemia when it's increasing, and if you wait long enough, also the renal function, the serum creatinine will increase. So these early stage biopsies are probably not informative, and if we then move on and wait too long, then they become informative, but then to kind of get back by reducing immunosuppression might be a difficult way to go about. So what we really want to do is be sure that these patients have the anemia, either it's high enough or persisting, then reduce immunosuppression judiciously, stepwise, and then at the lowest point, we may actually consider re-increasing immunosuppression because otherwise we might run into rejection. And here we have to again look at the induction protocols and at the immunological risk. Sometimes the immune reconstitution will cause inflammation that also impairs allograft function, and for this then we need to look at the virus-specific T cells that are increasing. Unfortunately, they don't show as painted bubbles, and obviously over this maneuver the chance increases that we have an alloimmune response and outright rejection. So really here is a window of opportunity for re-increasing immunosuppression. Antibody levels are maybe predictive at transplantation, but it's a little bit of a debate if they are informative over the course. And as you know, some centers like decoy cells, which are evidence of very high urinary viral levels, which we can detect very early. And just to remind you, just a positive detection of virus in urine does not distinguish a kidney transplant patient from a healthy individual. It's really the excessively high levels, and we are not sure we can use the course of these two urinary markers over time. So really everything centers around the anemia. So how do we do this in an algorithm? So kidney transplantation, then we go on screening and we ask, is the anemia detectable? And then the levels become important, either persisting or very high. And if that's the case, then we should reduce immunosuppression and follow up with corresponding serum creatinine for renal function, as well as for the anemia. And if by this we can clear, then there may be the opportunity to reconsider increasing judiciously immunosuppression. Now, if there's a increase in serum creatinine, we have to ask if there's a higher immunological risk, or if we now think that this patient is at risk for rejection, or at this stage, if we want to decrease immunosuppression, there's a high immunological risk, we should consider a renal allograft and integrating all the information from the side of pathology. If there is no rejection and we look at the BKD anemia, there's no, at the BK nephropathy, there's no more BK nephropathy, we should reduce immunosuppression. If there is rejection, then we should first treat rejection and then reduce immunosuppression at a second stage. If we can detect histologically the BK nephropathy, compare the two gradings, BANF and the AST-IDCOP. So how should we reduce immunosuppression? And there was a lot of debate, and obviously this is a complicated chapter. In principle, it says, please adjust the immunosuppression to the anticipated or the projected level that you wanted to do this. And then secondly, either stop the anti-metabolite first, which is the American way, or reduce the calcineurin inhibitor first, which is more the European or the Basel way. And in the end, both of these pathways converge. And then when the patients do not completely clear BKD anemia, then we are at a very difficult stage of high-level hand waving. So even these guidelines can't help you much more. So future directions in management are really, we need randomized clinical trials to identify or to understand the role of intravenous immunoglobulins, the neutralizing monoclonal antibodies that are currently being evaluated, and adoptive virus-specific T cells. And maybe BK vaccines and new antivirals can help us to prevent and treat BKD anemia / nephropathy. In the pediatric session, what's notable here is that there's a significant number of patients, 10 to 20% of patients that develop BKD anemia later. So they recommend screening until the 3rd year post-transplant. And then the other interesting point is that even in patients with stable renal function, pediatric patients, because of the large for size organ, maybe we cannot detect an increase in serum creatinine. So we should consider a biopsy in those with persistent high-level D anemia. And obviously, and I have not mentioned that for the adult part, there's no role for leflunomide, cidofovir, fluoroquinolones because of the lack of appropriate studies. So that is the same between adults and pediatrics. So the future directions is to look at the immunological markers for risk stratification and treatment, the same for antibodies and cell-mediated immunity, and obviously antibody and adoptive T-cell therapies. Finally, there was a cost-benefit and retransplantation working group, and they looked at the benefits, and they came up with data and also published these in the meantime, that applying this routine screening as suggested by these guidelines would be associated with improved clinical outcome and is cost effective, and one should not decrease the frequency of the screening algorithm. So there was a very strong statement for first one and with B evidence, and a weak statement for the second one with B evidence. So the future direction and cost benefits says let's look at this very carefully. For example, with patients with persistent BKD anemia, how long should we actually follow up on them, who are at the lowest possible level of immunosuppression? And then also, what is the cost effectiveness ratio, for the immunological markers once we have identified how they can help us in managing. And finally, the retransplantation section was that retransplantation can be considered in otherwise eligible patients who lost their prior allograft from BK nephropathy. And the idea is that BKD anemia should be resolved prior to retransplantation, and there's no uniform recommendation for graft nephrectomy, especially in those that have undetectable D anemia. But these points need to be looked at as future directions we need more evidence for these recommendations. And with this, I like to tell you that this was a great meeting. We had a constructive interaction, and I'd like to thank you and also Marta for participating actively in the guidelines. Thank you.
So thank you very much. If you want to join us, I think we will have the opportunity to have 3 questions in the audience. Robamos unos minutos a la...
5 o 7 minutitos tenemos para preguntas desde la audiencia.
Allí hay una pregunta. Preséntate, por favor, que te veo borroso.
Sí, soy Fernando Caravaca del Hospital 12 de Octubre. So my question goes to Dr. Van Loon. So thank you, Elizabeth, for the great presentation. And well, as you know, I'm more into glomerular diseases, and I would like to ask you, what are your recommendations in these patients with underlying glomerular diseases? Would you recommend to go ahead and perform a protocol kidney biopsy in these cases, or would you rather individualize based on other laboratory workup or risk factors, considering the underlying challenges both in the diagnosis and therapeutic management? And what would be the ideal timing for performing these kidney biopsies?
Thank you for your question. Thank you for your question, Fernando. Yeah, I'm not sure. I don't think there's any guidelines on performing protocol biopsies after kidney transplantation for patients with glomerular disease originally. But in my personal opinion, this would not change my protocol biopsy program. I think whether they have an original glomerular disease, I think you especially do the protocol biopsies to detect autoimmune damage and adapt your immunosuppressive regimens. Although, of course, it's always very interesting to see on the protocol biopsies if something is returning. Although, for example, in IgA nephropathy, you might see some IgA on the immunohistochemistry already without any signs of other IgA nephropathy glomerular recurrence. So it's not always going to change your or have therapeutic implications. And I think also there's other things to follow in some other glomerular diseases, like the ANCA titers or these kind of things. And this is far away from the protocol biopsy reasons that we are why we are doing them right now, I think. But it's always interesting to still see if you're doing a protocol biopsy, if you see some lesions recurring, and then you can maybe adapt some immunosuppressive drugs on it. But I think the main reason would be to detect autoimmune damage.
Fede?
Oppenheimer from Barcelona. Also a question for Dr. Van Loon. When we detect a subclinical rejection, microinflammation, and so, we need to decide whether to treat, to not treat, or what kind of treatment doing. But the second question is, how can we assess that we have solved the problem? Because this was subclinical, so we need to do a follow-up biopsy. Have you any data on how many of these patients are really re-biopsied, and what is the timing for the second biopsy and the success of this? Have you any information about this?
Yes, a very interesting question. So I think as you saw the treatment, there is very little consensus on treating. And I think for TCMR grade 1 and 2, there was quite some consensus on the steroids. But if you find microvascular inflammation, especially if you don't find any DSA, there is very little consensus on treating these subclinical ABMRs. And then I think indeed to follow up, it's very difficult. And it was also in this European survey whether these centers perform follow-up biopsies after finding these rejection, and there is very little consensus on. So I think European centers are very much differing on whether they perform a follow-up biopsy to detect the resolvement of these immune injury that I have seen. In Leuven, in my center, we don't systematically do these follow-up biopsies, but indeed it's true that, okay, you treat these patients, but you don't know if it's gone or not.
A second question for Dr. Hirsch, please. Many times we have the problem that we have an overlap of rejection and infection in these patients, no? And we have to decide whether to treat the rejection. My question, have you any idea how to treat steroids, baseline immunosuppression, both, or wait and see?
There was a lot of discussion about how to distinguish the two, and especially since in some cases the nephropathy is the consequence of rejection treatment with intensification of immunosuppression and steroids, which also pertains to subclinical rejection. We're inviting more BK once we treat that. But it's still very difficult to do that. I think the criteria for the ABMR, there you should follow the Banff criteria, and that was relatively easy, whereas for the TCMR, especially the interstitial presentation still cannot be distinguished. And I think here the pathologist together with the clinical team needs to make a probability decision if now steroids would rescue the graft function. Those usually have an increasing graft function. If you have baseline and not an increased immunological risk, then you don't even need to do the biopsy. It will not change your management. It's most likely all inflammation that you would see is then due to the virus. But the longer we wait, the more the virus will cause inflammation. And so we get into this terrible situation where we don't know. And probably most clinicians would then decide on treating rejection first because they see some benefit of it, but then don't forget to reduce maintenance immunosuppression if the anemia is at a significant level.
¿Alguna otra? My question is for Dr. Hitch. In retransplant patients, what do you recommend initial immunosuppression, especially in high immunological risk patients? Or is nephrectomy, previous nephrectomy, is possible in these patients initially?
I think this is also a difficult issue because we have two competing risks. I think the majority of the nephropathy events are transplanted with the virus. The virus is coming with the transplant, so that's what you're concerned of, and so not so much super infection from the old graft, but the old graft is shedding virus via the urine and may backwash via the bladder, so sometimes we probably need to consider to remove it. However, if the anemia is cleared, this suggests to us that there's enough BK virus-specific immunity, so your major objective is to accommodate immunologically the graft, so choose it as you would do for any other retransplantation.
Tenemos Juan Carlos.
Ruiz from Spain, sorry, from Santander. Dr. Hirsch, I have a question. Do you have any information about those patients receiving immune suppression before kidney transplantation? For example, patients with a previous lung or a heart transplant. And is there any possibility that the risk of BK viremia to be more frequent in those patients due to the previous immune suppressive state?
I think it's conceivable because those that actually do need heart transplants are typically older individuals and has been going on for a while on the transplantation. So if they have not seen the virus for a long time, there would be, but I don't have any data in my head. And I would actually send this question to the immunologist. So Oriol Bestar should come up with an assay to tell us how good is the immunity for BK and what is the risk between anti-donor immunity and antivirus immunity. Where can we make the best cuts?
Yeah, but I don't know how to answer because actually the frequencies of BKV specific T cells are really, really very low. So if you compare, for example, to other viruses such as CMV, for example, which is I would say, the gold standard, I think it's even 10 or even 100-fold less. So that's why I'm kind of really hesitating whether this is going to really help, because the differences between a patient that never developed viremia or controls viremia spontaneously from those that really goes beyond and develop P1 may be really from very, very low differences. So I think, I don't know, at least in peripheral blood, it's going to be pretty tough as compared to CMV.
Y para acabar, una última pregunta a Oriol sobre imlifidasa. Muy interesante el efecto que has mostrado, ¿no?, de algunos de vuestros pacientes sobre las switch memory B cells. ¿Tenéis alguna idea de cuánto dura ese efecto y si eso puede ser una ventaja extra, ¿no? Porque estamos hablando de listing, nos permite trasplantar a pacientes, pero los trasplantamos con DSA que están, bueno, cerca del flow cross-match, que no llegan, pero son pacientes de alto riesgo. El AIDS, además de darnos la ventana, ¿nos puede dar otras ventajas a medio y largo plazo con el efecto sobre memory B cells?
Sí, es muy buena pregunta, Marta. De hecho, el problema que tenemos con imlifidasa es que hacemos una virguería y luego los ponemos con triple terapia como el paciente estándar, ¿no? Entonces no tiene ningún sentido, ¿no? Es decir, mecanísticamente me refiero, ¿no? Y en este sentido estamos ahora evaluándolo y analizando a ver si esto ayuda, aporta algo más, ¿no? Simplemente para saber si el origen de estos anticuerpos, ¿no?, que hacen el rebote vienen fundamentalmente de la médula ósea, ¿no?, de long-lived plasma cells, o vienen de periferia de memory B cells, ¿no? Y el rebote de memory B cells es automático, como habéis visto, ¿no?, igual que los anticuerpos solubles. Pero el uso de rituximab va muy bien, es decir, que aquellos anticuerpos que se producen por la fuente periférica, ¿no?, o sea, por memory B cells, realmente quedan inhibidos y depleccionados. El problema es saber antes del trasplante, y ahí viene un poco necesitaríamos un estudio mucho más mecanístico, ¿no?, el cómo utilizamos, ¿no?, tratamientos anti-plasma cells y rituximab en combinación o no, o a lo mejor co-stimulation blockade para no el paciente tener que vivir y responder a BK, ¿no?, porque esto es otro problema, ¿no?, que podemos tener en estos pacientes. Pero sí que el rituximab, sea pre o post, lo que hace es en aquellas células que producen anticuerpos sí que lo reduce, pero no parece que sea la gran mayoría de anticuerpos. Si uno mira el espectro anti-HLA, pues hay muchos, pero a lo mejor de los 2, 3 DSAs que tú has aceptado, ¿no?, a lo mejor ninguno de ellos viene de memory, viene de long live, ¿no? Entonces a ese paciente el rituximab a lo mejor es useless y le iría mejor un anti-CD38 o tal, ¿no? Pero yo creo que esto tiene que ir por ahí, ¿no? Porque si no hacemos el all for all de siempre, ¿no? Y no acabamos de entender el por qué algunos van bien, ¿no?, y otros en cambio rebotan drásticamente, ¿no?
Gracias. So thank you all. We have a lot to learn and to do research in the different areas, and it's been a pleasure to have you all here. And I hope that you can enjoy a little bit of Mallorca.